Hello, thank you for inviting me to speak at this important meeting. My name is Andrew Davidson. I'm going to talk about an update on the TREX trial and the challenges with clinical studies looking at the neurotoxicity of anesthesia in children. I have no financial relationships with commercial interests to disclose that are relevant, and my presentation does not include discussion of off-label or investigational use drugs. One of the aims of the clinical studies looking at neurotoxicity is to try to determine whether the neurotoxicity exists or not. This is not the first time when we have been faced with the issue of trying to discover if an anesthetic is toxic. This is an editorial written in 1979 by Eager and Anaesthesiology, where he's talking about halothane toxicity. And I'll read it. This brings me back to my initial point, the problem of discovering non-existence. Obviously, when what you're searching for doesn't exist, you'll have trouble finding it even with an infinite number of experiments. Although halothane or enflurane or diazepam or Inavar may not be toxic, you cannot construct a study that will conclusively document non-toxicity. Long ago, my father warned me that I could not disprove the existence of dragons. So the first challenge of a clinical study into neurotoxicity is that we can never conclusively prove they are never toxic. We can, however, provide some evidence where they may not be toxic or less toxic. Remember that best clinical practice is always driven by a synthesis of evidence of varying quality, certainty, and relevance. There's rarely such a thing, or never such a thing, as the definitive study. There's always uncertainty around estimates. There's always variations in populations, exposures, and outcomes. Clinical research is not simple. So what is a logical framework for clinical studies in this topic? What should be the progression of how we seek to unravel this issue? Firstly, we have to ask ourselves, is there biological plausibility? Then we may go on to see if there are any observed associations between anesthesia and bad outcomes in humans. We then may see what exposure is associated with what outcomes. We then may try to determine if we can identify possibly causal relationships from those studies. That may give us the basis for what we might think is something that's plausible for a trial, which would then lead to the question of what interventions might improve outcomes in those trials. Firstly, is there biological plausibility? Yes. It is biologically plausible that anesthesia exposure may have a lasting impact on neurodevelopmental outcome. Numerous animal studies have suggested that there is a biological plausibility to this premise. It is also, of course, biologically plausible that other perioperative factors may have an impact. We'll come back to that later. Is there any association seen in humans? Yes, there are now numerous observational studies that have found evidence for associations, although those studies have not all looked at the same thing, and there is some heterogeneity in what they've found, but there are reasons for that. First challenge in determining what is associated with what is to look at the exposures. There are multiple possible exposure types. You could have a short or a long anesthetic. You may have multiple or single anesthetics. You may have different types of anesthetics, and you have different ages of exposure. And lastly, you may have quite different patient groups. There's lots of different possibilities for the exposure. Then, if you're thinking what is associated with what, the second challenge is that there are multiple possible outcomes to look at. We could look at behavior, cognition, memory, executive function, motor skills, learning disorders, or specific disabilities, such as autism or ADHD. The implications of this is that there are a large number of permutations. There are many combinations of exposure and outcome that could be examined. This causes a significant risk of type 1 error. An apparent association is seen just due to chance because we are looking at so many. To mitigate this risk, we need very large numbers, and studies must be replicated and repeated. And findings, if we are to think that they may be true, need to be seen across multiple studies in similar populations, with similar measures and similar outcomes. There is a tension in where we should look first. Should we look at what is biologically most likely from preclinical studies, as in long exposures and perhaps in younger children, and maybe look at those domains such as behaviour where there is some evidence in primate studies? Or should we look at what actually matters most to families and societies, which would probably be shorter exposures in older children because that's where the greatest number of anaesthetics are, or look at things like school IQ diagnosis or a significant disorder, which has the greatest impact on the child. Number 4, can we identify possible causal relationships? There are various ways of determining if there's a causal relationship in clinical studies, and these have been summarized by an excellent editorial in Anaesthesiology by Randy Flick and Dave Warner some years ago, and they used the Bradford Hill criteria, which basically means that you are likely to see a causal relationship if there's replication across studies, if there's similarities within and across studies, if there's a biological gradient, if there are strong associations with large effect size, if there is minimal confounding, and if it can be proved by experiment, i.e. randomized trials. Confounding. Confounding is when an external factor influences both the exposure and the outcome. All observational studies are subject to bias and confounding. Adjusting, controlling, and matching can reduce confounding, but can never eliminate it. There are examples of confounding in the association between anesthesia exposure and neurodevelopmental outcome. Socioeconomic status. Some patient groups may be more likely to need to have an anesthetic, but also more likely to have a poor neurodevelopmental outcome due to their socioeconomic status. Children with existing diagnosed or undiagnosed neurodevelopmental problems are more likely to need surgery. For example, dental surgery, procedures, ear tube insertion. Children who have poor hearing or some behavioural problems are more likely to have an ear tube insertion. The surgical indication may also impact development directly, for example, obstructive sleep apnea. The surgical indication associated with a specific genetic condition that also impacts development will have an impact. Or the surgical indication may be associated with a non-genetic condition that also impacts development, such as prematurity. There are also perioperative factors which may cause confounding, such as inflammation, hypotension, cerebral ischemia, stress, pain, and hospitalization itself. To help identify causal relationships, we need large studies because they have greater precision and reduce the risk of type 1 error. We need multiple studies. They have to be varied and they have to be replicated, as I mentioned before. We need to try and control for confounding. However, it's almost impossible to disentangle the effect of anesthesia and other perioperative factors. The best way to identify causal relationships is through randomized trials, which we'll come back to in a minute. When trying to determine if there's causality, it is also worth considering causal diagrams. And this is an excellent toolbox which was published in Anaesthesiology recently by Amy Gaskell and Jamie Slay. And here it gives a tutorial on how to look at causality in large population-based studies, such as those that are looking at neurotoxicity. We often assume there's a simple causal relationship, or like this, but in fact, it's more like this, where X may cause Y, but there's a whole lot of other factors which interact that relationship. If you draw a causal diagram, that can help you understand whether you're facing something simple or more complex. It's likely that in the not too distant future, all these population studies will need causal diagrams. So I strongly recommend that you read this article. What are the plausible bases for trials? Well, firstly, you'd normally do a trial where there's strong evidence for an association in observational studies. You would do it where there is biological plausibility that the intervention would work in that specific population. And you would do it where and when and in those that it matters. So, if we were going to do such trials, we'd ask ourselves what interventions improve outcomes in trials. Would we do a pragmatic, or we could do an efficacy study? The pragmatic study is a broad population, whereas an efficacy study is in a tightly controlled population. We could do it where the populations and outcomes, in those populations and outcomes where there is the greatest observational evidence and biological plausibility, or we could do it in the populations that have the most anesthetics and the outcomes that matter the most to the families and society. When we consider the intervention, we may also decide a balance between a biological plausibility of non-toxicity versus a safety and ease of administration. Do we do it in an agent which is highly likely to be non-toxic, but very unsafe and difficult to actually administer? That would be a trial which is of little value. Whereas we might do a trial where it may be less biologically plausible that something is non-toxic, but it's a very feasible anesthetic to give and a feasible alternative. Other challenges of trials are that you need sufficient numbers of children to show smallish differences, and there are not that many children in those risk groups that have anesthetics, particularly long anesthetics. You need to find good evidence for a non-toxic intervention. And at the moment, there is some difficulty in finding what would be the most non-toxic intervention when it comes to neurotoxicity. There's a problem, there's a lag between when you deliver the exposure and when you assess a child. The older the child is, the more they may grow into any injury. And also at an older age, you can measure more domains of neurobehavior, particularly executive function. It would be great if we had surrogate outcomes such as a reliable biomarker, but I think we're still quite a way away from actually having a really reliable biomarker of neurotoxicity in children. And lastly, it's not just neurotoxicity. If we do find associations, there are other biologically plausible explanations which may lead us to consider other types of trial. Maybe we should be looking more at hypotension and pain and stress. The TREX trial. The TREX trial is a neurodevelopmental outcome after standard dose sevoflurane versus low dose sevoflurane, dexmedetomidine, remifentanil anesthesia in young children. It's a multinational, multidisciplinary consortium with dozens of collaborators. It's funded by the NHMRC, ANSCA, the Italian Ministry of Health, and numerous departments. There are many people involved in the TREX trial around the world. Why the acronym? Well, it could be that TREX stands for toxicity, remifentanil, dexmedetomidine, but it was originally designed as the killer trial. It was going to be the trial that was going to prove that anesthesia was safe by having a long duration anesthetic in young children with a least toxic anesthetic compared to a most toxic with a comprehensive neurodevelopmental follow-up. This proved to be probably not the best aim of the study. So rather than aiming to prove that anesthesia is fundamentally safe, it shifted to a superiority trial where we're seeing if one treatment is plausibly superior than another, and only provides indirect evidence to address the fundamental issue of neurotoxicity. And this goes back to what I was talking about before, where it's unlikely a single trial or a single study will definitively answer the question of neurotoxicity. The trial enrolls 450 children under 2 years of age with planned anesthesia for greater than 2 hours, with sevoflurane 2.5 to 3% in the standard of care group and a lower dose of sevoflurane with dexmedetomidine and remifentanil in the other group. The children are followed up at the age of 3, where we measure their primary outcome being the IQ with the Wechsler preschool and primary school intelligence scale, but a number of secondary outcomes looking at cognitive function, language, executive function, memory, adaptive behavior, clinical behavior, and social skills. We need 190 in each group to have a 90% power to detect a difference of 5 points. That's a third of a standard deviation in IQ based on two-sided test with an alpha of 0.05. This is our recruitment graph. We've been, like all trials, we started slowly back in 2017, but more recently we're picking up speed and we're hoping to finish by the middle of next year. These are the sites that are recruiting well in Australia, the US, and in Italy. We have recruited 223 children so far. More sites are coming on board in Italy, the US, and hopefully Spain. The follow-up is underway in Australia and in the US. We'd finished recruitment in 2022, the final results back in 2025. What's good and bad about the TREX trial so far? The bad is that there's not many suitable children having long anaesthetics. Most children having long anaesthetics have other comorbidities that exclude them from the trial. We're facing an exhausted funding environment when it comes to neurotoxicity. It's difficult to get neurotoxicity studies funded now. COVID has had an impact on recruitment and a substantial impact on follow-up. It's very difficult to do neurodevelopmental tests remotely. The children have to come into hospital, and that's almost impossible during COVID. The good is the protocol has been easy to follow. We are gaining momentum, and we have an ongoing strong collaboration in spite of COVID. So in summary, there's still a place for large cohort studies to identify the nature of associations of neurotoxicity and outcome. Confounding will continue to limit their ability to identify causal relationships. There is a place for more carefully designed trials, but they're expensive and long. And perhaps it's time to think beyond neurotoxicity as well. Thank you for listening.